Check one.
Hello. Hi. There's a patient by the name of Procos, P-R-O-C-O-S, was admitted that we were told this morning admitted under surgery. But he's actually on the second floor, admitted under review, and I got to see him late this morning. Do you know anything about him? Right. Right. That's you. Yeah. So basically, so they admitted the patient under review with this delirium. He apparently was had some episode last night where he was delirious. Now, he's now not delirious. So I went and spoke to Terry Pang. I guess this is based on his CT findings. Terry says that this is not a surgical problem. That's not, he doesn't have an infection. And so he's going to see the patient. I thought he was admitted under surgery. And I went and found Terry in the desk of GI suit. So right now, he's basically admitted with not much of the stuff. He's not deliriously walking around right now. He has some peripheral edema, which I think is related to his radiation. He has an open wound in his rectum from the surgery previously. But, no, so I think that so it would be under your chief. Okay? Thanks. Yeah, what happened? Yeah. Yeah. Good. Okay. I'm in Grand Round, so why did you come down? Okay.
Gary?
Hey, how are you?
Good, thanks.
Are you going to get support from your RASP troop today?
That's a good question. We have European Respiratory meeting in Madrid this weekend, so I don't know if some of them have already left. I think the CF team will come down, though.
You're not going to the meeting?
No, there's too many meetings. Like, there's the American Thoracic Society. ERS is really gaining momentum in terms of followers. I think mainly because of the U.S. No one wants to travel to the U.S. anymore from Asia and the Middle East, right? So they all go to the European meeting. And yeah, it's supposed to be a good meeting. I've never been, actually. We have North American CF meeting around in October, so it's just too much travel. How about yourself? What meetings do you go to?
I do a lot of meetings. I do a lot of Royal College stuff.
Hi. Royal College stuff. Okay, so a lot of travel back and forth from Ottawa.
Oh, really? Yes, okay. Yes, okay. So if the plastic surgeon doesn't agree.
Oh, I think the plastic surgeon will say, yeah, I first we need the private. But my question to them is, like, if you guys have options for
She was like sandwich.
Yeah. But I think that if not, then I still would call John.
Sure, yeah.
Okay.
yeah.
Good, it's up. And you still, I didn't do it last week, but you still want me to block that out the way it is now and not show all the other sites, right? And if by some chance people want to see the other sites, they're down on that far screen.
Good.
It's just little boxes, basically.
Okay.
All right, sounds good. That's good, that's good. This is ready to go if they want it. It's on. Check, check, check. All right, and that's it.
Good. Thank you.
Okay, awesome. Yeah.
Do I need anything? Do I need to go?
No, you're hooked if you want.
Is this on?
I can just use the mic if that's okay. Is that easier?
Yep. I think that's ready to go. Just have a look. Is it on? Yep.
Okay.
So we'll wait for a few minutes.
Sure, yeah.
Is it a full hour?
No. We're okay.
Chris, how's that patient doing upstairs?
Trauma survey, I don't know.
Oh, I talked to you on board yesterday. You appreciated the note.
Oh, okay.
It's all done. He said it's fine. He's glad it's fine.
Yeah, okay. Yeah, please.
Okay. Yeah, and it's for, actually, I told him over. Did you go to the meeting this morning to talk to you?
No, I haven't.
Yeah. Did he not?
Usually bring it, sure.
Leftovers and
Well, you know.
Hi, Debbie. How's it going? How you doing? Good, good. How are you doing? I'm good. How are you guys? Thanks for that info. Oh yeah, I was a little surprised when he mentioned it. I decided to look it up. I've never heard of that. But it's a higher case. Oh, I didn't know that. Great. We can all use that. Been doing this?
I sent him a message.
Sounds like normal. Maybe. Oh yeah, maybe not. And also
Yeah, no, I know, just sent it.
Interesting. So maybe the arthropathy
So what's that?
Head pressure, or, ATK pressure,
I've never even heard of that. You know, there's so many of our patients.
Congratulations, you were. Yeah, I'm actually like in admin.
Something routine with all of that. You know.
6 months.
I've never had that before.
Where are you sitting?
Where is it? It's on DB. Oh, really? It's called about. Oh.
Whenever you like, yeah. It's all good.
Good morning. Welcome to Grand Rounds. As you can see, the title of the talk is Variants of Cystic Fibrosis for the General Internist, and I'm assuming that this is a different disease than it is for the respirologist, but I guess we'll find out. Brad?
Thanks. Yeah, it's going to take me outside of my comfort zone and speak beyond the lungs today. Thanks for those of you that are able to make it today. I know a lot of my colleagues are on their way to Madrid for the European Respiratory Conference. So, yeah, can't blame them for not being here today. So just by way of disclosures, conflicts of interest, we are quite active in CF research in terms of clinical trials, so I do have a lot of disclosures in that regard. And I am medical lead of a Canadian clinical trial network, so it leads to increased interactions with industry. I will be discussing off-label use of a product today, so I just, in full disclosure, I just want to bring that up right now. So learning objectives. So if you're going to take anything home today, I'd want to make sure that you understand and can describe both pulmonary and extra-pulmonary manifestations of CF. Review the diagnostic criteria for CF versus CFTR-related disorder. Does that sound familiar, that term, to anyone? Maybe to some of the CF group. And then briefly introduce you to some of these novel therapies targeting CFTR now. And actually it has led to a renewed interest in making a diagnosis of CF, because previously you could maybe make the diagnosis, but would it change how you would treat the patient? So I'm going to start this off with some cases. We don't have this specific patient, but a very similar patient to this. I took this one from the literature, mainly to illustrate a point that we'll come back to a bit later. But it's a 24-year-old without any respiratory symptoms, obese, who comes in with recurrent pancreatitis. So you guys probably see that a lot on CTU. Do abdominal ultrasound. There's no gallstone disease. CT abdomen, no pancreatic duct dilatation to suggest any anatomic abnormality there. But on the upper cuts of the CT abdomen, you see a bit of bronchial wall thickening in the lungs. That prompts you then, despite the lack of respiratory symptoms, to do a spirometry. Actually, the FEV1 to FVC ratio is normal. FEV1 is 90% predicted. Take a further family history. There's no history of CF. Although, interestingly, the brother is a carrier and was diagnosed as a carrier mainly as part of an infertility workup. He had stopped drinking. Obviously a concern about someone with recurrent pancreatitis would be alcohol driving that. And oftentimes, I think in CTU, we even talk about weird things like scorpion bites that lead to recurrent pancreatitis. And if they tell us that they're not drinking, we assume they're drinking even though they deny it. And this astute internist thought maybe this could be CF. They ordered a sweat chloride, which was 57 millimoles per liter. For those of you that don't know the cutoff, it's usually 60 and above would be diagnostic for CF. So this is kind of in this intermediate category. You do some genotyping and you identify actually two mutations, delta F508, which is the most common mutation, and R017H. So the question is this CF or a CFTR-related disorder? Case 2, a lady actually we have seen in our clinic over the last year with recurrent pneumonia, a 37-year-old. She's grown Staph aureus in her lungs on bronchoscopy, and she's been diagnosed with quote-unquote celiac disease. We did a CT chest. She's got mild bronchiectasis. She's got really normal lung function still. And we looked up, tried to work her up for immunoglobulin deficiency. That was normal. She's got no family history of CF, and we did sweat chlorides. She had a sweat chloride of 38 and 41, and her standard genotyping was negative. So is this a CF or CFTR-related disorder? Case 3, a 23-year-old guy, also seen in the last 6 months, from India, who had a prior history of asthma, sinusitis, and a persistent cough. He was actually referred in by a community respirologist because of bronchiectasis, and he was suspecting, could this be CF, not based on ethnicity, because usually we talk about CF being more common in Caucasians, but the fact that a sibling had passed away in childhood from a respiratory issue. This is back in India, so the details are a bit vague, but he's also underweight. Sweat chlorides were done, and they were 60 and 72 millimoles per liter, and 2 mutations were identified, L218X and 3849 plus 10 kb C greater than T. Bit of a mouthful. So is this CF or CFTR-related disorder? And then the last case we have is a 27-year-old smoker with asthma with unexplained abdominal pain, weight loss, and steatorrhea. CT scan was done in the chest to see if there's any bronchiectasis, which was negative. Normal lung function, and normal fecal fat and fecal elastase. There doesn't appear to be pancreatic insufficiency to explain his steatorrhea. He had sweat sodium done out in the community that was high at 75, and then was followed up with sweat chloride measurements of 42 and 48, and his genotyping was negative. So lastly, is this CF or CFTR-related disorder? So some of you in the audience may not know what CFTR-related disorder is. I will come back to this a bit later. But this just kind of, we will come back to these cases and hopefully give an answer to these at the end. So just to back up a bit and explain what causes a CF. So it's a monogenic disease caused by an abnormality in a single protein. So it sounds like it's pretty straightforward then, but it's actually quite complex. This protein is actually quite complex, and it's an ABC transporter protein. It's got 2 membrane spanning domains, 2 nuclear binding domains, and an R domain. So when it's in its closed state, it's not able to secrete chloride. When the R domain gets phosphorylated, it leads to the nuclear binding domains coming together, and it opens up the channel so that chloride can be secreted. So there can be mutations anywhere along in this protein leading to abnormalities, and we'll go into that a little bit later. So why is chloride secretion so important to our body? Well, it's on the apical surface of the epithelial cells that line any lumen or duct in our body. So why is that important? So chloride secretion is important because sodium and water follow it. So if you don't have chloride secretion, you have a lack of sodium and water. And that leads to, really viscous secretions. Whatever that duct might be, or if it's an airway, for example, it can lead to sticky mucus. If it's a duct within the pancreatic duct, it can lead to thickened, inspissated secretions within the pancreatic ducts. What is often overlooked is the fact that CFTR is also a bicarbonate channel as well. And bicarbonate actually plays an important role in a lot of these secretions. And the reason why bicarbonate secretion is decreased is because if you don't secrete chloride, you have less exchange of the chloride for bicarbonate. So as a result, it's actually a more acidic fluid environment that you have, either within the airway or in the lumen. So yeah, CFTR is expressed in the upper airways, lower airways. It's in the biliary ducts. It's in the pancreatic ducts. It's in our intestines. It's in our sweat ducts, and it's in the reproductive tract, particularly in males, within the epididymis and the vas deferens. So CFTR in the airways, you can see the CFTR channel here, and when you have less of the fluid being secreted, you get a thicker and stickier mucus, which is a perfect breeding ground for infection. One other aspect that has been found out over the last few years is the fact that lack of bicarbonate actually increases the risk for infection, because the antimicrobial peptides that are in our airways, they don't work as well when they're in an acidic environment. So the lack of bicarbonate secretion actually impacts on the ability to fight off infection. And so when you get recurrent infection, you get airway damage, which is bronchiectasis. In milder forms of the disease, all you get is bronchial wall thickening and some mucus plugging. So you may not actually see damage to the airways. Within the pancreas, so this is going a bit beyond my comfort zone now, but chloride secretion and bicarbonate secretion do occur within the pancreatic ducts. And if CFTR is not working, you actually get a very low flow state due to a lack of water and a very acidic fluid that's very protein rich, and this precipitates in the pancreatic ducts, leading to obstruction and damage. So if you have a patient that is very mild CF, they have a normal working pancreas, that sludge within the pancreatic ducts can set you up for a recurrent pancreatitis. But those that have already had complete destruction of the pancreas, they're not at risk for getting pancreatitis, but they have pancreatic insufficiency from the repeated damage that's already occurred. Sometimes this is already occurring in utero in the fetus before they're even born. But by about 4 years old, about 90% that are going to develop pancreatic insufficiency do so already. And when you have enough pancreatic damage, then you can get diabetes as well. So you actually get insulin insufficiency. In the biliary ducts, it's pretty much the same story. So low flow states, low pH causes bile to kind of obstruct and damage the biliary tracts. It's a bit different than other cirrhotic disease that you guys see in the sense that it tends to be focal biliary cirrhosis, depending on where the obstruction is occurring. And so the synthetic function overall of the liver can actually be quite preserved still, but they can still develop the manifestations of liver disease because sometimes the fibrosis is around the portal tract, so they can get really bad portal hypertension, splenomegaly, and I know Dr. Casson here has seen a few cases that ended up on CTU previously with bad liver disease. Fortunately, it's a minority of the CF patients that actually develop severe liver disease, less than 10%, and usually that manifests during the pediatric years. We don't see a lot of progression once they hit the adult years. What we do often see, though, is asymptomatic liver enzyme elevations, and a growing concern is steatosis, so fatty liver. The mechanism of this is not that well understood at this point, but we do encourage quite high-fat diets in our patients, so whether there's increased fat deposition, there's probably unexplained factors. We don't understand it fully enough at this point. And then intestinal tract. So chloride and water transport in the small intestine, if it's deficient, you're going to have a lot more dehydration within the bowels, and that'll lead to sticky mucus, and the stool will just stick to it and can cause obstruction. So when that happens at birth, we call that meconium ileus, where it blocks the terminal ileum. In adults, we call that distal intestinal obstruction syndrome. So oftentimes, fortunately, our patients do not require surgery. We do opposite of what you would normally do in bowel obstruction. We actually give them osmotic laxatives. They drink it. Sometimes we need an NG tube to help break it up. But knock on wood, I don't think we've ever needed surgery here at St. Paul's Hospital. Sometimes in the post-transplant setting, surgery is required. Sometimes with the stool being so bulky, you can get intussusception, so the bowel just telescopes on itself. We haven't seen that too often, although we did see a case this past year. And then in the sweat duct, so the sweat gland secretes chloride, and actually in the sweat duct itself, it's totally opposite. So you would think that, like based on what I've explained so far, that CFTR secretes chloride, and then therefore you would think that the sweat chloride would be low. In the sweat duct, it's responsible for reabsorbing chloride. So it makes it really confusing. And that's why if it doesn't reabsorb the chloride, the sweat chloride ends up being high. And that's actually what we use as a diagnostic test for cystic fibrosis. So conveniently, sweat chloride is a pretty good biomarker of your CFTR activity, so how well that CFTR protein is working. So as you see is when you have less CFTR protein activity, your sweat chloride is higher. And as as your CFTR activity increases, your sweat chloride decreases. So here's the cutoff at 60 millimoles per liter to diagnose CF. And this also reflects on the phenotype as well. So when we read about CF in textbooks, that's kind of classic CF, where the sweat chlorides are typically above 100 and they have 0 to 5% CFTR activity. But when you start getting into milder forms of CF, you actually have residual CFTR activity in the range of 10 to 20%, and the sweat chlorides are just slightly elevated, using the 60 to 80 range. And then when it gets even more challenging is when we get into this intermediate sweat chloride range, which we refer to as CFTR-related disorder, where sweat chlorides are between 30 to 60, and they actually have enough CFTR protein activity where their phenotype can be exceedingly mild, and sometimes the disease only affects one organ system. So the clinical phenotype is quite variable, and mainly because not only the CFTR genotype that affects the protein, there's also other factors like genetic modifiers and the environment, such as if your parents smoke at home, or if you maybe pick up certain infections early on in life that can make your phenotype much worse, particularly with respect to the lung disease. But it actually really depends on which organ system, how much these three factors play into the actual phenotype. So when you look at something like exocrine pancreatic insufficiency, it's largely determined by your CFTR genotype in the dark purple here. But when it comes to Airway's disease, the CFTR genotype actually plays a much smaller role, and it is more dependent on your gene modifiers and the environment. So this is what's contributing so much heterogeneity in the clinical presentation of CF, is that different organs are influenced disproportionately by the CFTR defect itself. So I'm just going to back up and just give you a bit of 101 on CF genetics. It's an autosomal recessive condition, and actually the carrier rate is quite high in the Caucasian population. We don't have tons of Caucasians in this room, but in general in Caucasians, like 1 out of like the 25 of you would probably be a carrier of CF, which is quite common. It being an autosomal recessive condition, you know, it's still rare to develop CF because you need 2 carriers to come together. And even if they did come together, it's only a 1 in 4 chance that they're going to have an affected child. The gene responsible for CF was first discovered back in 1989, as published in Science, actually by a group of researchers in Canada and the US. And initially it was the F508del mutation. That's like the most common mutation in the CF population. 90% of our patients have 1 copy, and about 40% have 2 copies of this mutation. But over time, they've now identified over 2,000 variants in this one gene. And we now refer to them as variants as opposed to mutations, because mutation kind of connotates disease. And we know that all these variants don't necessarily cause disease at this point. So, but there is over 2,000 variants in the gene. So just, there are 5 mutational classes. I'm just going to quickly go over them. So there's the class 1, 2, and 3. These lead to minimal CFTR function. And the main reason for that is there's very little CFTR protein being produced. In class 1 mutations, there's actually a premature stop codon, so the protein doesn't even get produced. In class 2 mutations, which is delta F508, the protein is misfolded and it gets destroyed by the internal quality control system. In class 3 mutations, which we call gating mutations, there's actually a mutation in that R domain that I talked about earlier, where the channel doesn't open at all. So even though there's CFTR at the surface, it just doesn't open very efficiently. So these 3 classes lead to minimal CFTR function. When it comes to class 4 and 5 mutations, we refer to these as residual function mutations, meaning there's a fair amount of CFTR at the cell surface, but it either doesn't conduct chloride very efficiently, or there's slightly diminished amount of CFTR just due to increased turnover. So when we talk about genetics, we can look at the combination of the mutations. It's an autosomal recessive condition. And the phenotype usually is determined by the most affected allele. So you can be a carrier here and even have very minimal function on your second allele, but as long as you have 1 allele that works still, you will have a very mild phenotype. In fact, you won't have a phenotype at all. If you have 2 mutations that are very mild, you can lead to a CFTR-related disorder where your sweat chlorides are typically 30 to 60. When you have a residual function mutation with a minimal function mutation, then you have milder CF. And this is kind of classic CF where we see minimal function mutations on both alleles. So in some circumstances, genotype is pretty good at predicting the phenotype of the patient. So here we have F508del and P67L, which is a residual function mutation. This leads to residual CFTR activity, and the sweat chloride is about 70 to 90 overall at a population level. And if you're a male, you're going to have absence of vas deferens. And you have delayed lung function decline, and you have pancreatic sufficient status. So, you know, you can kind of predict the phenotype. It sounds pretty straightforward, but it's not always so straightforward. We now have an idea of like what each mutation causes in terms of disease liability. They've actually taken 89,000 patients worldwide and put this in this one database where they've now looked at all the different combinations of mutations and phenotype these patients based on registries. So you actually know, okay, to what extent, if you have 1 mutation combined with another, what would you expect in terms of their phenotype? And so out of the 2,000 variants, they've now characterized about 400 of them. And as you can see, 84% are CF causing, and a bunch of them, we really don't know the functional implication of the actual variant. But there's like 1,200 mutations where there's like less than 5 individuals affected worldwide, so it's really hard to know what implications those variants are. there's not enough people to make any general conclusions yet. So here's going back to the airways disease. I said there's a lot of heterogeneity, and it's mainly because CFTR genotype has a minimal influence on your lung function. It's mainly influenced by genetic modifiers and environment. And as you can see here, at the age of 20, all these individuals with, that are homozygous for delta F508 have a wide variation in their FEV1, despite being the same age and having the same mutation. So that just goes to show what influence these other factors are having. And they've now identified 5 different loci within the genome that can modify lung disease. And some of these have to do with other aspects of ion transport, your inflammatory response that can then influence your phenotype. One interesting kind of research that's come out in the last decade is the fact that cigarette smoke actually affects CFTR function. And so this one paper where they looked at sweat chloride measurements in a bunch of smokers, some of them that had COPD, was that they had elevated sweat chlorides compared to the general population, suggesting that it not only is it could have effects in the lungs, but also systemic effects on sweat chloride. And when you map this out relative to sweat chlorides and CFTR activity, it's clearly more than what a carrier, more dysfunction that a carrier would have. So it could lead to potentially a phenotype. And they've actually been able to distill this down within cigarette smoke to acrolein, which is a chemical that's leading to CFTR dysfunction. So here's a number of smoking-related conditions like sinusitis, chronic bronchitis, infertility, and pancreatitis. We don't really know the mechanism of smoking leading to these conditions, but the theory is potentially that CFTR dysfunction due to smoking is kind of predisposing to some of these abnormalities. Here's one study that looked at the lower airways, and they looked at the amount of chloride being transported in smokers versus non-smokers. And as you can see, that the amount of chloride transport was reduced in the lower airways. So I think some of these smokers that have chronic bronchitis, CFTR dysfunction, could be contributing to the actual phenotype itself. So in summary for this kind of first section of the talk, there's certain organs such as the male genital tract and the sweat duct which are highly influenced by your CFTR genotype, but there are other things like the extent of your airways disease that are influenced by other factors. And so it is a spectrum that leads to the heterogeneity in the clinical presentation. Okay, so now I'm going to move on to criteria for diagnosing CF. Is there any questions I can take at this point that you may have related to the heterogeneity in clinical presentation, or? We're good? Oh yeah, go ahead, Alex.
So based on what you're saying, then, if an individual had 2 different variants of your condition, they may clinically not have it at all.
Exactly. So it depends on the severity of the mutation. So if the variant led to residual function of the CFTR protein, and you may not even have any clinical phenotype. But it can be very heterogeneous because you can be a carrier and develop a phenotype, but that is probably a result of other factors, environmental factors, gene modifiers. So that's why it becomes a bit complex. Okay, so just reflecting on some of the cases that actually presented earlier is that this one patient actually chronicled her experience going through the healthcare system and not being diagnosed with CF until the age of 33 years old. And she was actually elated to find out she had been diagnosed. It was like she had won the lottery, because it kind of validated a lot of the symptoms that she had been describing to doctors over the years, but was never given a unifying diagnosis. I would say that, for the most part, in individuals we've diagnosed as adults, they share a similar feeling. There are the odd ones that are totally shocked and blindsided by it, but I would say most of them feel validated and feel that we can actually help them. Sorry. So why does a diagnosis of CF get missed? I don't know if anyone reads the Harrison textbook of medicine anymore. I know everyone relies on UpToDate now. But it's due to the lack of clinical suspicion. So we always think about textbook CF that are emaciated, have severe particularly in a non-Caucasian. We don't tend to think about it, but it often gets missed more so in non-Caucasians than Caucasians. We often think they're too old to have CF, and there's a lack of knowledge on how to even begin the testing process for CF. So I'm going to cover a few of these points. So when you look at the CF disease prevalence throughout the world, it is enriched within countries of Northern European descent. So you can see it in Ireland, actually 1 in 1,400 individuals have CF. That's quite a high prevalence. Here in Canada, it's more in the range of 1 to 2,500, 1 in 3,000. You see these gray zones on the map. They have never really been characterized. Like some people say in the range of 1 in 30,000. We really don't know. If you're from India and you come in with bronchiectasis, they're going to assume you have TB. They won't even look to see if you might have CF, even if you're at a very young age. So we really don't know the prevalence in certain parts of the world. Worldwide, we think there's about 70,000 cases, but I think it's probably much higher than that. So this is data from our Canadian CF registry, and as you can see, about 5 or 10% of our overall CF population are diagnosed as adults. And I suspect this proportion is increasing over time. I know we've seen that in our CF clinic, and I think because now there's potential treatments for CF, that increases the, I guess, the motivation to make this diagnosis. So when we compare, we did a registry study where we compared all the adult diagnosed CF patients to all adults that are in the overall registry. And as you can see, they're older. Well, there's no age overall, just because a lot of these were born at a younger age. And they're less likely to have delta F508, which is a minimal function mutation. Only 5% of our overall Canadian CF population have that are diagnosed as adults are homozygous for delta F508. And they have a higher lung function, slightly lower rate of Pseudomonas infection, and a much lower rate of pancreatic insufficiency and lower rates of diabetes. One other thing I should comment is their BMI is around 24, so they're clearly not malnourished. When you break down all the different symptoms that they present with, there usually is some sort of pulmonary symptoms in about 60 to 70% of cases. But some do present with GI symptoms alone, and some have minor manifestations such as clubbing that was picked up by a doctor. This just breaks down the mutations that I was just kind of already, I don't know what happened, all these got switched. But anyways, the blue color is the homozygous delta 508. So a lot of these patients have residual function mutations, or we only identify one mutation, yet they have diagnostic sweat chlorides. So here's the diagnostic guidelines for CF. So if you have signs and symptoms that would be suggestive, you should start with a sweat chloride test. Do you guys know where to send patients for sweat chloride testing? It's a bit of a, you would think that we have the adult CF clinic for the province here at St. Paul's, but we don't actually even do sweat chloride testing here. So we send them all to children's hospitals still. There's not a high enough volume for it to be done here, and it is a bit of a technically finicky test. If you're not doing enough of them, the results may not be as valid. But if you have a diagnostic chloride of greater than 60, you have CF. If you're less than 30, CF is fairly unlikely, although some of these carriers are probably in that category. This is the gray zone where we have a lot of difficulty with when the sweat chlorides are between 30 to 59. You should be repeating the test as the first step, and then genotyping them if they're still in that range. And if you're able to identify two CF-causing mutations, then they have CF. If you have no mutations, CF is unlikely. I would say that if you had an intermediate sweat chloride, it's unlikely you're going to identify two CF-causing mutations. Usually you'll identify one. You may identify two, but the second one might be of undetermined significance. So the guidelines would then recommend that you actually undertake further physiologic testing of CFTR. And so I'll come back to this a little bit later. And then if that's abnormal, then you can maybe define them as CF. But I would say in most cases, we still don't know, mainly because we don't have access to this testing here in Vancouver. So sweat testing is actually a challenging thing to do. Not everyone sweats like this guy here. So they have to actually at Children's Hospital, what they used to do is wrap them in saran wrap, put on a whole bunch of like warm clothing, and make them run up and down the stairs to get them to sweat. We now use chemicals like pilocarpine and electrodes to help draw the sweat out of the sweat duct. Apparently early in the day there was patients that would die from dehydration from like having to be bundled up in saran wrap and excessive amount of clothing. So fortunately we do have this easier test, particularly when the patient's of a younger age. Out in the community, they don't all have sweat chloride, so you may request a sweat test, and you might get a sweat conductivity test or a sweat sodium. Sweat conductivity will reflect a balance of both chloride and bicarbonate secretion, and it tends to overestimate sweat chloride by about 15 millimoles per liter. So if you send a patient up in like Prince George for like a sweat test, they're going to do a sweat conductivity. If it's above like 75, then it's probably the sweat chloride could be above 60, and then it's worthwhile following up with a sweat chloride test. But the CF Foundation does recommend them as still a screening test. They can be used, but to confirm the diagnosis, you need a sweat chloride. There are some things that can cause false positive sweat chlorides, like malnutrition, dehydration, and a lot of conditions that really shouldn't be confused with CF, like glycogen storage diseases, ectodermal dysplasia, untreated hypothyroidism, and some medications like topiramate or Topamax and arsenic poisoning. So if you were to go on and do some genetic testing, the panels have actually expanded over the years. Before, when you would order a standard panel, it would only test for 23 variants in the gene. And I mentioned there's over 2,000 now, right? So it'd be fairly narrow in scope, but because the more common mutations are represented in 90 to 95% of patients, it's still got a pretty good sensitivity. They've now expanded to 130 variants, and it's still 95% sensitivity. You expand to 333 variants on the expanded panel, and your sensitivity does not improve. But it does increase the pickup in patients that are of like non-Caucasian descent, for example. And if the standard and expanded panels are negative, then you then move on to sequencing the gene. And that'll increase your sensitivity to 99%. Why does it still miss 1%? There can be duplications within the gene itself that unfortunately get missed with sequencing. So yeah, going back to this gray zone area in terms of these intermediate sweat chlorides and genetic testing that may be non-definitive. So we have this resource called CFTR2 where you can actually put in the mutations and it'll give you kind of what would be expected to be the phenotype based on the particular combination of mutations. So this has been a helpful resource. When we get back genetic results, we don't know how to interpret. And this is the other CFTR physiologic testing that can be done to interrogate the CFTR protein, because the sweat duct, in some patients you can't even get a sweat chloride, maybe just, despite all of our techniques to try to get sweat out. So you can actually put a probe up the nose and look at chloride transport that way, or you can take a rectal biopsy and in tissue culture look at chloride secretion. Unfortunately, these tests are not available here in Vancouver. We have to send patients off to Toronto to get these done. So coming back to my question earlier, what is CFTR-related disorder? So it's essentially patients that have some phenotype that would be related to CF, but they don't fulfill the diagnostic criteria, meaning they have an intermediate sweat chloride and less than 2 CF-causing mutations. So this is kind of that area where we have a lot of difficulty, even in, you send a patient off to our clinic, we still have difficulty determining, do they have mild CF or do they have a CFTR-related disorder? Mainly because we can see patients with sweat chlorides between 30 to 60, but a severe phenotype, and say, well, they're kind of acting like CF, but it could be the other environmental gene modifiers that are leading to their severe phenotype. And likewise, we can see patients with elevated sweat chlorides, but only isolated manifestations, such as maybe a bit of pancreatitis. And do they really have CF is the question. It's a bit of semantics if you think about it, because we arbitrarily set the cutoff at a sweat chloride of 60. So where it lies, plus or minus 10 or 15, it probably is of trivial significance. So some of you may be asking, if you're a carrier, can you develop CF-like disease? They've done a lot of studies where they've looked at CF carrier rates in individuals with sinusitis compared to the general population. And as you can see, the CFTR variants are enriched in patients with sinusitis. In bronchiectasis, in chronic pancreatitis, there's increased detection of CFTR variants. So it suggests that CFTR is playing some role in all these conditions to some extent. So I think this illustrates it well. In the case of chronic pancreatitis, you can see that these are all CF carriers because they have wild type with a CF mutation. If you were to combine it with other mutations that also predispose individuals to pancreatitis, then it's playing some role in the condition, in addition to environmental factors like alcohol and nicotine. So yeah, it's clearly, CFTR role in this setting is more of a complex disease, complex trait, compared to it being a more Mendelian inherited disease where it's a monogenic condition. Any questions before I move on to the last section of the talk? Okay, so I just want to introduce you now to some novel therapies targeting CFTR. So for quite some time with respect to bronchiectasis management, we're focused more on this vicious circle of mucus obstruction, infection, and inflammation. So how do we target mucus? We use mucolytics like Dornase alpha to break up the mucus. We use saline to help hydrate the mucus, and we use airway clearance techniques to help get mucus up along with exercise. To treat infection, we use inhaled antibiotics, and in inflammation, we use macrolide antibiotics that also have anti-inflammatory effects. But now with the advent of CFTR modulators, we can potentially target upstream. And I know a lot of respirologists out in the community now are aware of this, and they're looking more for CF as being the underlying driver of the bronchiectasis, as opposed to just, assuming that, it's just due to an idiopathic cause. So back in late 2000, first decade of 2000, there was a company called Aurora Pharmaceuticals that did small molecule screening. They looked at around 200 or 300,000 different small molecules, and they looked at within epithelial cells, could they increase chloride transport? And they came up, they hit a home run with this one molecule called ivacaftor. And as you can see, the chloride transport increased from 5% at baseline all the way up to 45, 50%, so approaching like a carrier type status. When they looked at the sweat chloride of patients after they applied this molecule in an early phase clinical trial, you can see the sweat chloride drop by about 48 millimoles per liter. So I mentioned earlier that a lot of the patients with classic CF would have chlorides of about 100. You would drop it below the diagnostic range. So this is kind of what I was just talking about. Could you lessen the phenotype by improving CFTR activity? So did this result in improvement in clinical outcomes? Within 2 weeks of starting this treatment, patients had about a 10% improvement in their lung function. And it probably didn't reverse the bronchiectasis in the lungs, but it helped hydrate the mucus, and all the mucus was then able to get expectorated. It's kind of like opening the floodgates. We know a lot of our patients have like just solid mucus in their lungs that don't move for years. And finally, this medication is helping to hydrate the mucus. So we don't really know exactly how ivacaftor works still, because it was a small molecule screening approach. They just looked to see, okay, which molecule helps increase chloride transport the most. But we think it probably binds somewhere next to the R domain to help with the channel opening to increase chloride secretion. And so this therapy has now been applied to a number of gating mutations, and also some of these residual function mutations like the class 4 and 5 mutations. But what about the delta F508 where you don't actually have any protein produced whatsoever? The same company, Vertex Pharmaceuticals, has come up with these other small molecules that help with the folding of the protein. So you're actually having more of the protein being transported to the cell surface that increases the CFTR quantity and indirectly should increase protein activity. So we actually now have in the CF population 2 CFTR correctors, lumacaftor and tezacaftor, that are now being combined with ivacaftor to increase CFTR protein activity. So coming back to this kind of adult diagnosed population, could we help them by adding these small molecules? So this study was done and published in New England Journal about 2 years ago now. These were patients that had delta F508 and one residual function mutation. So it was a list of 25 different mutations that were included. And at a population level, these patients had lower sweat chlorides, like less than 86. They were more likely to be pancreatic sufficient, and they had at least some demonstration in vitro that their cells would respond to ivacaftor. And it was a crossover design. They were only on treatment for 8 weeks, but they did get combinations of either ivacaftor or tezacaftor-ivacaftor versus placebo. Here's the patient population that was looked at in the study, and you can see that it's a bit of an older group, and they had lower sweat chlorides than what we would typically see, and lower rates of Pseudomonas, and a higher BMI. Actually, some of these were borderline obese, very low rates of pancreatic insufficiency. And as you can see here, that within 2 weeks, once again, of starting these small molecules, there was about a 5 to 6% improvement in FEV1. And there was a greater effect with tezacaftor-ivacaftor compared to ivacaftor. So it suggests that the tezacaftor is probably helping the delta F508 component, and the ivacaftor is helping with the residual function / gating mutation. The question you may have is, some of these patients that are pancreatic sufficient did help with their gastrointestinal symptoms. They didn't see any significant change in things like fecal elastase or anything like that, but a lot of these patients were not symptomatic with their pancreatic disease. So I think the jury is still out, and you probably need a longer treatment duration to see if there's any gastrointestinal effects. It was only 8 weeks on treatment. So if you look at all of our adult diagnosed CF patients, I did mention that the mutations are very different than our childhood diagnosed population. And about 50% of our patients would actually qualify for CFTR modulator treatments. And so I think there is a renewed interest in trying to diagnose CF as an adult. Although we are stuck in a bit of an ethical dilemma because these medications cost about $300,000 per year, and our publicly funded healthcare system does not pay for them. So is there much point in diagnosing them with CF if we can't actually treat the underlying problems still? So until a lot of these therapies come off patent, I think we will all continue to struggle with this. Okay, yes, we've diagnosed you with CF, and there's this great therapy that could potentially treat it, but we can't access it. Some of our patients through extended health benefits have been able to get access to these $300,000 drugs, but majority have not. But I think in 15, 20 years, when some of these drugs are off patent or if there's more competitors, the whole landscape will change in terms of our ability to treat these conditions. So I'm just going to come back to these cases that I introduced you with earlier. So this 24-year-old with recurrent pancreatitis, is this a CF or a CFTR-related disorder? I think, they got 2 mutations, but the sweat chloride is not diagnostic, right? So the big question is this second mutation here CF causing or not? If you go to CFTR2 and look it up, they say it is very important to look at that clinical criteria alone be used to determine whether this patient has a CF or not, because it can be a variable clinical consequence, the R17H. We now understand that there is another, I don't want to complicate things too much for this audience, but there's another variant known as the poly-T-tract that affects the amount of CFTR protein that's being produced. So if you have a 5T, then you're producing less CFTR protein with R17H. If you have 7T, you produce a little bit more. If you have 9T, you're actually producing a normal amount. So it does depend on the complex genetics as to whether the patient will actually have CF.
There will be a second bed meeting at 1300 hours in the medical...
You guys better start working on your discharges.
Your attention, please. There will be a second bed meeting at 1300 hours in the medical record hallway. There will be a second bed meeting at 1300 hours in the medical record hallway.
Okay, so yeah, this patient, I would probably diagnose them with CF because they have recurrent pancreatitis, even though the sweat chloride's not diagnostic. But again, it's in one of those kind of borderline ranges, whether you want to define it as CFTR-related disorder or CF, it's a little bit subjective. So this is the case report that was from the literature. So this patient was having pancreatitis, about twice per month. and then they put the patient on ivacaftor. So if you think about it within the pancreatic ducts, now the secretions are moving a bit better because you have increased chloride and water transport and more bicarbonate. And you can see that during the time on treatment for about 1.5 years, the patient had no episodes of pancreatitis. And then when they were lost to follow-up and stopped the medication, it recurred again. So I think, this is good as we have at this point to suggest that maybe CFTR modulators can kind of modify some of these other manifestations of CF beyond the lungs. I think with time we'll find out more. So this other patient, 37-year-old, 2 intermediate sweat chlorides and a negative standard panel testing. The next step would be to then go on to expanded testing and then sequencing. But if all that was negative, this patient would fall in a category of CFTR-related disorder. It's unlikely to be the only cause of her pneumonia and recurrent pneumonia, so obviously looking for other explanations would be reasonable, including an immunodeficiency workup. Our 23-year-old from India who had a sibling that passed away at a young age with 2 diagnostic sweat chlorides and 2 mutations. So when I look these mutations up in CFTR2, you can see the 3849, which is a residual function mutation. But when you look up L218X, it's not there. It's because he's of Indian descent, and some of these just are not reported yet. But likely this is going to be it's a class 1 mutation, most likely, leading to truncated protein and lack of protein production. So I don't think without any doubt this patient has CF. It's quite common for our patients to be diagnosed with asthma before they eventually get a diagnosis of CF. And in our last case, a 27-year-old smoker with asthma and maybe some signs of malabsorption. We did the fecal elastase was negative and the fecal fat was negative, but he's got some CFTR abnormality based on the sweat chloride. So he probably has a CFTR-related disorder, and there may be other factors leading to his abdominal symptoms. So I hope I've demonstrated that there's many different faces to CFTR dysfunction, and you have to be aware of it, even think about it, just because it's so subtle. Maybe not as subtle as Donald Trump is, but subtle nevertheless. So in summary, I hope I've demonstrated that CFTR dysfunction is a spectrum disorder. It's not like what you see necessarily in textbooks. The adult diagnosed CF is a difficult one, and it's often milder. Some of these patients can be obese and pancreatic sufficient, and they have slower lung disease progression. And CFTR dysfunction is now treatable. Whether we can access these therapies, we are having trouble in the more classic CF population to get these therapies. So to suggest that we would use it in very mild CF or CFTR-related disorder may be a bit of a stretch, but one day it may be possible. So with that, I'll take any questions that you may have. Thank you for your attention.
Any questions for Dr. Quon?
Yeah, go ahead.
It was on forever and I couldn't get it off now. At an individual level, how much variability is there with sweat chloride testing? Like if you are batting around this potential diagnosis and you get a measurement, is there going to be a bigger distribution if you keep checking out the same individual?
Oh yeah, we've seen that a lot in our CF clinic. It's very technically finicky. So large studies where they've looked at thousands of sweat chlorides, it can vary plus or minus 10 to 20. So if you're running in a range where you're kind of borderline, it could make a difference between CFTR-related disorder versus CF.
Absolute 10 to 20 on.
Yeah. When you're up at 100, if it's classic CF, you're not gonna misclassify someone. But when you're in that borderline category, it's more likely to be, off. And when you repeat it, it tends to be lower for whatever reason. I don't know why, but when they've looked at these studies and repeats.
Any other questions? How many patients are you treating with the therapy in your clinic?
Oh, okay, yeah. So we have because we've had a lot of patients get on the therapy through clinical trials. So I didn't mention, but there actually is better treatments than the ones I just mentioned. They have now a second corrector, so it's a triple combination therapy. We have 5 patients on that therapy right now, and we have another 15 to 20 maybe 15 to 20 on ivacaftor or lumacaftor ivacaftor or tezacaftor ivacaftor. So about around 25, 30 out of our 300 patients.
And who supports that? Is that they're all through clinical trials?
Yeah, so the pharma company has provided it free of charge. So they usually have a placebo-controlled aspect, then they have an open label, and then they do give it through compassionate access afterwards.
Okay.
So yeah, there's huge motivation for CF patients to get in these clinical trials right now because that's the only way to access these therapies.
Good. No other questions? Thank you very much.
Thanks.
So you said that patients with clubbing, were you talking about?
Yeah, we don't, they usually have bad, yeah. But in the registry, they said that the only manifestation was clubbing. I don't believe that. Obviously, they have bad lung
We
disease.
have a person who's developed clubbing in the last 2 years. He's
Yeah.
been around the block, another internist said to me,
Mhm.
he has nothing except clubbing. He's up in his hands and feet.
You done a CT of his chest?
Yeah.
Okay, and it's normal. I don't think clubbing would ever be the, like, unless they had significant lung disease with it.
Well, that's what I was saying.
Yeah,
So
yeah.
that's-
That's what the registry's saying, but
Well, I think I'm going to do some Florida.
might as well. You might get into an area where you're not.
Well, no, but
Yeah.
I mean, there's no other explanation.
Yeah,
Okay.
it's reasonable.
Thank you.
So out of the different clinical presentations of